Good morning, and thank you for being here. Probably we'll start. I don't want to add any words after the presentation of Dr. Satya. I want to say that I was impressed from his CV because I'm so sorry not meeting him. I believe that he was a real visionary man, a real, I don't know, a miracle. I can imagine so also because in these few days I met his family, Madam Shuma, no? Sushma. It's not so easy for me. I'm so sorry. Sorry. And nephew, grandnephew, fantastic family. Look at them. Are fantastic, both of them. And a clear harmony following what Dr. Satya explained clearly through himself to this excellent family. Plus, I want to say thank you at the beginning of this presentation to my colleague J.B. Sharma. I had with him, I don't know, 100 mails, around 100 mails to organize, and you were so clear with me, point by point, and I thank you very much. And I want to thank you also. Look at what I can imagine for a name. Jander, I don't know. I'm sorry, Jander, I don't know. But he was so nice in these days, always with us around the city, and thank you very much. So, going inside, maximizing ultrasound utility across obstetrics and gynecology. I want to communicate that my deepest aim doing this presentation is to clarify the principle of minimal invasivity. In my opinion, after so many years, she presented very well all the tiles, and my goal was always to reduce the invasivity, but not only because of small holes or laparoscopy or hysteroscopy. And I will explain why I am underlining that, because in my opinion, the first step is to do a very, very deep diagnosis. Absolutely, we have to go to our decision in terms of surgery or not surgery, in terms of medical treatment or not medical treatment during pregnancy, knowing step by step what happens. This is the real minimal approach, not a question of holes, not a question of permanent stay. Listen, I am a surgeon, and I started at the end of 80s and all the 90s to improve my knowledge in hysteroscopy, laparoscopy, and so on, going back, as the colleague said before also, in a different way, approving the minimal invasive surgery after a right diagnosis through mini laparotomic approach. This is more than true. It's not a news, but it's more than true. But everything is related to the diagnosis. You have to think about that. No we don't have to go directly to the operating room, not knowing in details what happens, because our goal is not to save anyone, but is the quality of life of women. And this is determined by a correct item in diagnosis. We will see, and starting with the obstetrical part of this presentation, I have to tell you that another good thing is to develop different technologies always for arriving to the best quality of life of women. And everything started in a familiar year, 1958. I was born this year, but there is no relationship with this kind of evolution. With this paper published by Donald, it was a Scottish scientist, and you will see in this group of pictures how many differences we have right now respect the past. And this is important. Up you see what was so many years ago. Come on, not too many, so many. And down you see the same pictures in a different technology and technological evolution. It's very important also this, and the stimulation of companies in developing this kind of evolution, and we will see in the future more and more steps in this is very, very important, because we obtained, and you will see, different appearance and different possibility to anticipate many diagnoses in obstetrician and also in gynecology. You see which are the focus: viability, confirmation of intrauterine pregnancy, uterine integrity, confirmation singleton pregnancy, fetal biometry, assessment of fetal anomaly, and nuchal translucency thickness, and assessing risk for common forms of an aneuploidy. This is not bad, because this is a program that we will propose to our patients in order to obtain the best results and an anticipation in terms of weeks in detecting eventual pathologies. Look at this picture and the quality of the results going back to the evolution of technology, but going back to the initial point about the importance of the anticipation of a diagnosis. In fact, in obstetrician, one of the goals is to reduce the number of weeks when we are able to give an answer to the patient in order to prevent, first, the information to the women, that is important. Second, in many cases, an intervention immediately after the pregnancy, and sometimes also during the pregnancy, because we can avoid many things, obtaining a very quick diagnosis, thanking our attention and the related technologies. You see, is common to have, as I said before, a diagnosis in the second trimester of pregnancy. We are trying for many pathologies to obtain that at the end of the first trimester, for the same reason as I told you. And you can see several pictures describing all you probably already knows, but again, our goal is to anticipate this vision and to understand what happens if we are able to anticipate that and to do something or to inform the patient. That is important too. Also, in deciding the worst choice, it's up to her. But we have to give to her more informations. And these are in details. In the left picture, you see the mid-sagittal view, the posterior approach of the cranial posterior fossa and aqueduct of Sylvius of the fetal brain, or the mid-sagittal view of the fetal brain. But I will continue with that to see also all the vascular potential diseases that we have to know and we have to inform our patient. And the other details, if you want, I can leave to you these slides and you can have with you, I'm talking with younger presence here, in order to obtain information day by day. I'm sure that your practice, you are absolutely able to have same pictures and same information I had, but it's up to you. I leave this to your availability to detect that. You see the sagittal view demonstrating the length of the fetal spine from the neck to the sacrum, and you see also the coronal view of fetal thorax and abdomen. These are all details that we can understand basically, and in case of pathologies. You see also the thorax as well as the three vessels and trachea view with a V-shaped configuration of the isthmus pointing left to the trachea. And then the hypoplastic left heart syndrome, very well described, and possible to be detected with a good evaluation by sonography. The common atrial, this is wrong, atrial trunk type 1, you see how clear is the images in a right detection, but also with a very good machine. Abnormal positioning of the great vessels aid to see if there is or not, is probably not, an evolution of the pathology detected as soon as possible. The transposition of great arteries. And this selection represents the few most typical anomalies whose diagnosis in the first trimester may have relevance for the further course of the pregnancy. That's the reason why I want to insist again, before we do, better is for our patient. And so other images to detect and 2D and 3D views of the primary and secondary plate, and also the identification in the first trimester, this kind of potential anomaly where you can do something, even if you have to wait for the end of pregnancy. Other amniotic band syndrome, normal amniotic membranes, you can see, and also acranial fetuses in the first trimester, that is important to detect, as well as the different phases associated with the holoprosencephaly from 6 different cases in the first trimester. It's not so nice to see this picture, but it's better to know that doesn't know anything to give an information to the mother. Twins at 12 weeks of gestation, dichorionic twins and monochorionic diamniotic twin, as well as the thoracic myelomeningocele at 12 weeks of gestation. You see the clearest picture on your left side and also on the right side. These are a list of the routine mid-trimester fetal ultrasound scan related to the cardiac activity, the basic fetal anatomy, the gestational age, the fetal size, placental appearance and location, amniotic fluid volume, all information useful for our patient. And the coronal views of fetal head is important to understand all details very well described about an ultrasonographic scan, as well as the sagittal planes of the fetal head and the transcerebellar view of the fetal head, progressive development of calcarine sulci is seen in this picture, as well as the intracranial signs of spina bifida, and you see the transverse section of the cephalic pole showing the posterior fossa of a normal fetus at 21 weeks, a 20-week fetus with lumbosacral spina bifida, ventriculomegaly, and concave frontal bone shaping the skull in a particular manner, and then, name it the lemon sign, and then the banana sign in the last, on the right side image. A spina bifida, well described in 3D and 4D ultrasound scan, and then the fetal cardiac imaging that you can see, the four-chamber view, the normality, left ventricular outflow tract view, the right ventricular outflow tract view, and the three-vessel and trachea view. These are very well describing the anomalies respect the physiological appearance. So also the polycystic kidney you can detect in around 24 weeks of gestation. And the dystrophic dysplasia that is always very well described in these pictures. Micropenis, hypospadias, cytoromegaly, clitoromegaly, and ambiguous genitalian synthesis is a useful information for the lady. The congenital scoliosis is an information to proceed as soon as possible in helping the newborn. Fetal skeletal dysplasia, you see how clear are these images, these pictures, coming from a good obstetrician, but also a good machine. Achondroplasia and Naegger's syndrome are very well described, and we can provide to anticipate everything. And at the end of this part of the presentation is the Down syndrome that you will know as the Down syndrome is unfortunately very diffuse. So we will hear about someone about artificial intelligence. And we believe that also in this field, ultrasound scan for both obstetrics and gynecology, artificial intelligence will reduce the number of wrong diagnosis, and I believe will help us. I don't think that we can remove the operator, even if we obtain from artificial intelligence a lot of suggestion, right suggestion, because the interpretation coming from the operator, but also the relationship between the machine, the operator, and the patient is and will be fundamental. The interactivity of the operator and the patient in this kind of field is fundamental, because part, and you will see talking about gynecology, part of the diagnosis is obtained through the interaction between operator and the patient. And this is the advances in the gynecological part. And I don't want to lose time for you, which is the role of ultrasound in gynecology. The routine examination, a potential emergency, a second opinion, and we will go. The endometrium evaluation is fundamental. You know, endometrium is inside the uterus. I know I'm talking with you. And all the informations are very important in order to detect if is useful, related to the symptoms referred by the patient, and medical therapy to avoid or to reduce the number of surgical approach, or if the surgical approach has to be mandatory. Many papers have been published in order to summarize and to have a right scheme about the different appearance of vessels, of deepest or not deepest endometrial signs, and is important to control, to have a definition in which we always can recognize what we are seeing through the ultrasound. The sonohysterography is an evolution of you remember the hysterosalpingography, the radiological approach. Now we can do the same and better, the sonohysterography, putting inside some fluid and detecting inside what happens inside the endometrium without discomfort with the patient in ambulatory setting. And in a few minutes we will have an answer to go after that to remove what we saw or we have seen, or to postpone the biopsy, or to go with an hysteroscope and to do a targeted biopsy in order to define the eventual presence of pathology. This is the color score evaluation that is important because some bad pathologies are a different scoring and color scoring of vessels inside. You see how you can determine. And you see also some common pathologies, benign pathologies, in the vast majority, not always, that are endometrial polyps. And before you decide if this images are related to a patient with symptoms, the next step will be a targeted hysteroscopy and removal of the polyps to have obviously an histological answer, as well as not being a polyp, just a deep endometrium has to be diagnosed by histology. or patient in treatment because of breast pathologies with tamoxifen. You can detect by ultrasound some variation, and you can answer the patient because you know the history of the patient, and you can also give a suggestion in terms of do a biopsy or not. Endometrial cancer is less better. Is a pathology in Europe and in my country is the highest rate of women gynecological cancers. Is a very, very bad situation because, and this is, you have to consider that going back to the start of my presentation. Also, this is a success because if we know and we anticipate the diagnosis of endometrial cancer doing a very, very targeted colloquium with the patient, and after that, starting from ultrasound scan and going to a biopsy, you anticipate the diagnosis, and we have excellent results in terms of resolution after 5 years, resolution of the incidence of this kind of pathology, and also considering the mortality rate. This is the power Doppler related to an endometrial cancer, as well as these pictures are describing also the three-dimensional appearance of the vessels. And another very, very important in terms of numbers pathology are the fibroids. You know, the fibroids are a benign pathology, but sometimes symptoms have to be considered not only because of the bleeding, but remember the first words, because of the quality of life of this women, or the need of a pregnancy, that is important too. Number, size, location, and vascularization. This is the FIGO classification, sub-classification of the leiomyoma, and you see on your left the different numbers that is easier to detect, to classify number 3, number 4, because you inform in more details not only the patient but also the colleagues in terms of evaluation at the end, what we have to do and in this case. And you see the different images related to the different localization of the myomas. Figure 0 means inside the uterus, and the solution is an hysteroscopic removal of that. Figure 3, you see, figure 1. I don't want to describe singularly, but just to express how important is the ultrasound scan and definition also this kind of pathology. The mapping is important too, because the kind of the intervention we have to propose to our patient and do to our patients is mostly related to the position and the need of our patient, because it's easier to remove the uterus, but a young patient has to be considered in terms of future evolution of her life and then desire of pregnancy. Ultrasonographic differential diagnosis will involve also a pathology that is not so well known worldwide. I'm talking about adenomyosis, that is an appearance, a different appearance of endometriosis. And believe me, I want to find this adenomyosis, okay, and we had also this MUSA, that is another classification, an assessment more than a classification, to detect adenomyosis and to consider adenomyosis in causes of infertility, abnormal uterine bleeding, pain, and why not postpartum hemorrhage. With this, we defined one of the causes yesterday during our meeting. And you see, this classification is very important because it's always a possibility to discuss, to exchange our ideas with other colleagues in the same way, going toward the patient with just one line of treatment, of detection month by month, and solution in order to better individualize the medical therapy or the surgical. But in adenomyosis, the medical treatment is more conservative and also with very good efficacy. You see, these are it's very clear the localization of the endometrial tissue, not inside the cavity, but inside the myometrium. That's the definition of adenomyosis. That is important, and we have to understand what happens in women with. You see both the images on your right that are very well describing the scheme you have on your left, in which you have a cyst, an hyperechoic islands, and the subometrial lines or buds that describe an echogenic appearance. And these are direct features with the ectopic endometrium. Endometrial tissue or endometrium is the same outside the normal localization. Again, other appearances echographically detected. You see the fan-shaped shadowing in the movie up on your right side is, for me, but I'm sure also for you, is clear that in images like this is a document in favor of a diagnosis of adenomyosis. But also the uterine malformation are important in the detection coming from ultrasound scan. And I have to tell you, this is in the vast majority of cases, as you know, is an asymptomatic condition. So patient will ask you why I don't become pregnant, how is my pregnancy? And you can find this kind of images by ultrasound scan, and you can inform again your patient, and you can suggest a eventual surgical approach. In this case, there are no medical therapies to remove this kind of malformation, but I have to tell you that doing a good surgical treatment by hysteroscopy or by laparoscopy, it depends on the uterine malformation, you can obtain whatever the patient needs. Overall, the possibility to become pregnant and to have a very good pregnancy with a good delivery time. These are several almost recent papers. These are, we go toward the end. IOTA is another classification related to the ovaries, because the ovaries have to be considered with attention, because is one of our enemy, is the most silent pathology, especially when the pathology is a very bad one, like the ovarian cancer. But we have to detect always during our consult with the patient what happens to her ovaries. And you see other papers that documented the appearance of different pathologies, or also different physiological situation in which you have an high sensitivity and high specificity in defining a benign condition. Also, these are the benign description of the adnex, and following this IOTA is always easier to communicate to patient and colleagues. This is a mucinous borderline tumor that you see and you can detect, and you see the appearance of the mucinous part, but also the different location in the back. You probably already have seen, so you can see with the multi-appearance of different cysts. And these are the vascularization related to the previous images that is very well describing that. And this is at the end, the 3D on your right, at the end with the removal of the ovary and the appearance macroscopically before the histology. At the end of this presentation, the cancer of the ovary, the worst, and the female part of oncology, the worst, because without any announcement, you can find not having a annual detection and evaluation of the patient. You can lose the patient because of this very, very bad and not so well considered in terms of the necessity. We have to see all women with or without symptoms at least annually, especially if there is a familiarity with some of oncologic pathologies. Another, deep endometriosis is one of the benign pathology, very, very symptomatic and very, very not very well known, but we have to consider that because it's very important in the evaluation of the possibility to reduce pain and infertility. In conclusion, what we said at the beginning, the technological developments are for us and overall for women necessary and are very, very well considered, and we wait for others. And don't forget that ultrasound guided procedure is now essential component of fetal therapy, IVF treatment, and overall all the detailed gynecological pathologies. If you have time, if you want to come to visit this city that is in Tuscany, you are cordially invited by me. University of Siena was born in 1240. That means one of the oldest university in Europe and worldwide. They will wait for you and for your visit. Thank you very much.